Assalamualaikum doctors. In this video I am discussing a video station that is about leukemia. So leukemia features the child can be present with they have fatigue, fever, petechiae and small red spots on the skin. So petechiae purpura we find they have a small lymph node, so cervical lymphadenopathy can be shown, abdominal distension or someone palpating the abdomen, spleen, kidney, liver, because they have splenomegaly, hepatomegaly presents, pain in the joints and bones, arthritis features, loss of weight, bleeding tendency or hemorrhagic tendency, so bleeding from different sites like nose bleeding, night sweating, anemia, pallor. So these are the features present with leukemia can be comes on the video. Then we can tell that this is maybe leukemia we find, and the differential diagnosis we can keep for leukemia are meningitis, sepsis, DIC, ITP, HUS, HSP, COVID and NAI. So leukemia, DD I am telling. First of leukemia, it can be non-accidental injuries, petechiae purpura. It can be henasculin purpura, another rash presents. It can be in DIC, bleeding, leukemia, infectious mononucleosis if the child is teenage age, cervical lymphadenopathy showing. It can be, these are ITP. So what are the history we ask? The history are onset, course and durations. What make it better, what make it worse? This is the always the first question. Then about the rash, onset of the rash, course and distribution rash, usually gradually over period. So distribution of rash is very important. Then the leukemia feature targeting, we are asking what is the night fever, weight loss, anorexia, pallor, palpitation, chest tightness, sign of increased intracranial pressure, abdominal distensions, abdominal pain, vomiting, swelling all over the body, any orificial bleeding. So leukemia feature are night sweating, fever, pallor, anorexia, repeated fever, and then abdominal distension, abdominal pain, bleeding from any side of the body. These are, and if we are keeping the DD, then DD related question. First of all, if NAI we are asking, so for NAI we are telling that is that the family registered to the social service or not. We are keeping here HSP. So HSP we are telling that is there lower distribution of the rash is important. We can keep their infectious mononucleosis, so any sore throat, any medication drug history. Then we can ask that ITP. So ITP, bleeding from any side of the body, plus without lymphadenopathy, without splenomegaly, hepatomegaly, and also ITP there is preceding upper infections. So these are the history we asked. Then we are going for the examinations. Examination as usual, AVC, vitals, examine the rash with the glass test, non-blanchable, examine the private area in the male for testicular affections, abdominal examination and lymph node examination, neurological and MSK examinations, chest and cardiac examinations. So examinations are AVC and vitals. Then where is rash, we do that the blanchable or not blanchable. We do the abdomen examination, very important, abdomen because hepatomegaly, splenomegaly, neurology examination, chest and cardiac examinations. So these are, and if male, private part because testicular affection occur. Then I am going to the investigations. So investigation, first of all, full blood count, that is normocytic normochromic anemia with low WBC and platelet, bi or pancytopenia, peripheral blood film for blast cells, bone marrow biopsy, blast cell is more than 30%. Then we are going lumbar puncture for CNS involvement, ABG and electrolyte for tumor lysis syndrome. Tumor lysis syndrome, we know, hyperkalemia, hyperuricemia, hyperphosphatemia and hypocalcemia. Coagulation screen, 10% of the patients has leukemia has DIC. Immunohistochemistry or phenotyping, or for immunohistochemistry or phenotyping for Philadelphia chromosome, genetic testing, PCR, radiology, abdominal ultrasound, chest X-ray for lymphadenopathy. For leukemia, what are the investigation we are doing? Full blood count, bone marrow biopsy, peripheral blood film, very important for blast cell. Then we are going tumor lysis syndrome, so ABG electrolyte. We are going DIC screening. We can do radiology, abdominal ultrasound. We are doing the Philadelphia chromosome and lumbar puncture if CNS involvement, immunohistochemistry and typing. So how can we manage the patient? First of all, as usual, AVC, air breathing circulations and dehydration status, vitals we manage. We involve senior here. We are treatment are that is blood transfusions, antibiotic, bone marrow transplantation is the curable, and chemotherapy, radiotherapy. Chemotherapy, the drugs are vincristine, cyclophosphamide and prednisolone. Okay, and multidisciplinary team involving my pediatricians, oncologist, hematologist, radiology, lies with the school, psychology, and family support. So multidisciplinary team, pediatrician, hematology, oncology, lies with the school, psychological support, family support. So these are radiology. Treatment are blood transfusions, antibiotic, chemotherapy, radiotherapy, and bone marrow transplantation. So what are the poor prognostic factor of leukemia? We know less than 1 year or more than 12 years. Before starting treatment, more than 50,000 cell count. After 1 month, it's not actually improving treatment. Philadelphia chromosome, hypodiploidy. Then Asian, male and African ethnicity. So male, testicular affection present. CNS involvement, tumor cell count before start of treatment more than 15 to 10 to the power 9 per liter. So you understand these are the treatment. They are telling what is the indication of bone marrow biopsy of leukemia. Non-blanchable rash, lymphadenopathy, profound pallor, hepatosplenomegaly, pancytopenia. Follow-up is oncologist accordingly to the hospital protocol. So if you find that is leukemia features is going, we do the bone marrow biopsy, that is, and oncology will be the follow-up. Thank you.